Hi folks, this is Alicia Bright. I'm going to be talking about acid-base balance. This is a basic introduction. Let's see. So acid-base balance, this is out of Giddens. This is defined as the process of regulating the pH, bicarbonate concentration, and partial pressure of carbon dioxide of body fluids. So basically, an acid is a substance that releases hydrogen ions, and a base is a substance that takes up hydrogen ions. Pretty simple math here. Low pH means you're acidic, and a high pH is basic. This goes back to your basic chemistry classes. The way it's balanced in the body has to do with acid production or intake, has to do with acid buffering, which are the systems we're going to talk about by which the body balances the acid base in the body, and acid excretion. Optimal acid-base balance keeps the pH of the blood and body fluids within the normal physiologic range of, here's your normals, 7.35 to 7.45. So this little picture here is sort of a balance of extremes. You can see on either end of the extreme you have death, but then there's this period of acidosis or alkalosis on either side of normal, during which time we can sort of correct things and bring us back to homeostasis, which, as you know, is always dynamic. The thing to notice on this slide here is carbonic acid is 1/20th as powerful as base bicarbonate is. So the bicarbonate has a much higher impact on balancing acid-base in the body. There are basically three ways that regulate acid-base, and we're going to focus on the second two. The buffer system is a cellular system. This is a very fast-reacting system. It's a very powerful system, and really what we're going to talk about is what happens when this system fails, because that's where we start having to step in and regulate. But the buffer system you should keep in mind also when we talk about our favorite old hyperkalemia problem. Because cells can take hydrogen ions in exchange for potassium ions, they can contribute to buildup of hyperkalemia in the body if things go unchecked. More on that later. That's one of those details that it's interesting to know about hyperkalemia and acid-base. We're not going to be very focused on that at this point. So what you should remember is that the respiratory system balances carbonic acid. How does it do that? Because air goes in and out. This is a very fast response. You can change your pH in your body. You can change your CO2 levels very rapidly. Just try it sometime. Try hyperventilating for 1 minute and see how it changes the way you feel. That's actually also the reason why just stopping and taking 3 nice, slow, deep breaths actually changes the way you feel. In part, it's regulating your acid-base system, but it also regulates your nervous system. So it's just a nice thing to remember about stress management. Okay, but back to acid-base. Your kidney system, your renal system, these regulate non-volatile acids and bicarbonate levels, but it takes several days to kick in, so it's very slow, but it's very powerful. So risk factors, of course, include excessive production or intake of metabolic acid. Like, when does that happen? Well, how about, we haven't talked about it yet, but diabetic ketoacidosis. That'll be a classic example of this. Also, starvation. Anytime your body goes into a catabolic state. Catabolic state is when you're breaking down your own proteins and fats. Anytime you go into that kind of a state, you're creating a little more metabolic acid in your body, and sometimes a lot more. So that's a risk factor. Then you might have too much or too little bicarbonate in your body. We'll talk about how that happens in a minute. You might have altered acid excretion. In other words, the kidneys aren't working right and they're not getting rid of what they should be getting rid of. That's another possibility. Or an abnormal shift of hydrogen into the cells. So There are four basic patterns of imbalance. They're classified as acidosis or alkalosis and respiratory versus metabolic. So you have respiratory acidosis, metabolic acidosis, respiratory alkalosis, and metabolic alkalosis. Oh gosh, how do you tell the difference? Well, we'll talk about that. So the way we define these things is it's based on the pH, not the reason why they have the problem. So this is a pattern of imbalance that's seen with many different physical states, many different illnesses, if you will. But we talk about this simply as its own state. Sometimes we treat it directly, but most of the time we try and treat the underlying causes of it. So what you'll see with acidosis manifestations, major manifestations are if someone has acidosis, they're going to be out of it. They're going to have central nervous system depression. You might see Kussmaul's respiration. If you remember, Kussmaul respirations are long, deep breaths in and out. Sort of sounds like this. Deep breath in, deep breath out, and they don't stop. If you do that for a period of time, you will get lightheaded because you're healthy and it's going to make you alkalotic. But if you had metabolic acidosis, it would blow off some CO2 for you and it would make you less acidotic by moving you closer towards alkalinity. So alkalosis is the other extreme. If you did Kussmaul's breathing, you'd end up with alkalosis if you did it long enough. You would notice you might start twitching, actually. Your CNS would be irritable. You might have numbness and tingling in your hands. You might have cramps in your hands, tetany, from alkalosis. It's actually a very strange feeling, and it can make people much more anxious if they already have some kind of psychological hyperventilation going on. They may just get really anxious. This can also happen with hypocalcemia. Now, you might get hypocalcemia with it. Respiratory acidosis. So why might you get this? Well, basically, you're not breathing well. Lots of reasons for this. You're not breathing fast enough. You're not breathing deep enough. Maybe you've got narcotic overdose going on. Maybe you have a head injury. Inadequate chest expansion. Maybe you've got broken ribs. Maybe you have fluid in the lungs. Maybe you have pain and you're not able to take deep breaths because it really, really hurts. Pleurisy as a complication of pneumonia, for instance. Maybe there's airway obstruction, either mechanical airway obstruction, somebody got that cherry caught in their throat and they can't breathe through it, or sometimes you might have trauma to the trachea or other parts of the chest and you can't get the air in and out. Or there's decreased alveolar capillary diffusion. Now we're talking a little bit more medical. This is what happens with COPD. This is what happens with asthma. Whenever you have a thickening in the wall of the alveoli, it's going to be harder to have the gas exchange and have that diffusion across that alveolar membrane into the capillary bed that surrounds the alveoli. You can get this anytime you have a dysfunction in the alveoli. Pneumonia, COPD, asthma, or anaphylaxis for that matter. Metabolic acidosis can be caused by, remember, that was respiratory, now we're talking metabolic. You can have too much hydrogen ion production. You can have underelimination of hydrogen ions. You can have underproduction of bicarb. This happens primarily with renal failure. These are often associated with kidney problems. You can have overelimination of bicarb. For instance, somebody with severe diarrhea. They lose a lot of their alkalotic bicarb through the stool. We mentioned before diabetic ketoacidosis. The body's breaking down its own proteins and creating ketones, and those are acidotic. Lactic acidosis is another situation. If someone is in an anaerobic state for a while, they can end up with metabolic acidosis. Starvation, again, the body breaking itself down, similar to diabetic ketoacidosis. A GI fistula, for instance, this is along the same lines as severe diarrhea. If you have a GI fistula and you have bowel contents draining through a hole in the abdomen, a fistula is a hole in the between a space that shouldn't have an opening to the outside world. You can have a lot of, you can lose bicarb that way. Or somebody who's in shock. Shock, again, is basically lactic acidosis. If you don't get the perfusion to the body parts, to the organs, to the tissues, they go into anaerobic metabolism and they start creating a lactic acidotic situation. Respiratory alkalosis is usually simpler. It's basically excessive loss of CO2 via hyperventilation. We can correct it pretty quickly because all we have to do is slow down the breathing. Well, that's not always as easy as it sounds. First of all, we can have someone who's very anxious, right? We classically think of a hyperventilating state as somebody who's freaking out and they're just breathing too fast, and you need to calm them down. We can talk about therapeutic communication when you're trying to reach somebody who's hyperventilating, and different strategies to calm people down. But there are other causes as well. One cause might be mechanical ventilation. We might be doing it to the person. Perhaps they're intubated and we've got the ventilator turned up a little bit too high. They've recovered a little bit and we need to turn it down. So that's when we use it in a critical care area to manage ventilator status. Don't worry about that till Med-Surg 3, but it's one way that you can have respiratory alkalosis. Another way is head injury. When someone has a bad head injury, often they'll that's one of the actual mechanisms that the body uses to try and decrease intracranial pressure. And so you might see someone hyperventilating with a head injury. Metabolic alkalosis can be caused by excessive intake of bicarbonates, acetates, citrates, etc. So there was an old recipe for upset tummy that started long before Alka-Seltzer and Tums and all those magic things that we've got for tummies now. You just take a little baking soda and put it in a glass of water, stir it up, and you drink it, and that would settle your stomach if you had kind of an acid stomach. Well, you do that too much and you'll end up with metabolic alkalosis. Anyway, excessive vomiting can cause this, or excessive NG suctioning, basically for the same reason, because you're sucking the acid out. Remember, the stomach contents a lot of acid. If you're losing that acid from the body's going to try and replace it from wherever it can. Of course, it's going to come out of the blood and create a metabolic alkalotic situation. Severe hypokalemia can also cause this. Thiazide diuretics, if someone's overdosed on those, can cause this, and hyperaldosteronism. So if you remember, aldosterone is one of the hormones released in the adrenal cortex. So we're going to try and assess somebody's acid-base balance. Now, we're not going to do this lightly. Remember, I said drawing blood gases is a very painful procedure. So it'll only be done when we really need to. The elements of the arterial blood gas are the pH, which we will look at first to determine what their acid-base balance is. Then the PaCO2, or the partial pressure of CO2 in the body, partial pressure of O2 in the body, oxygen, the level of bicarbonate in milliequivalents per liter, then the oxygen saturation, and then we're going to talk about base excess, and we're actually not going to talk about it too much at this point. It refers to metabolic acid. So the first thing you're going to do is to look at the pH and see what that is. That will tell you whether it's acid or base. Then you're going to look at the PaCO2. That's going to tell you whether it's respiratory or metabolic, because if it's high, you've got a respiratory acidotic problem. Then you're going to look at the PaCO2 pH relationship, and you're going to look at the bicarb, and then you're going to evaluate them for possible problems, the pH, the bicarb, and the base excess. You're going to look for compensation. Ooh, that's complicated. Actually, it really isn't. We'll talk about it and simplify it. Whenever the body's going out of whack, it's going to try and compensate and bring itself back into homeostasis. So we are interested in oxygenation, but when we're going for blood gases, it's kind of like the last thing we worry about, really. The Rome mnemonic is kind of an easy way for students to remember how to sort these things out. Rome mnemonic stands for respiratory, opposite, metabolic, equal. And what that means is in the respiratory situation, in alkalosis, the pH is going to increase and the PaCO2 is going to be down. In acidosis, the pH is going to be down and the PaCO2 is going to be up. In metabolic, if it's acidosis, they're going to be going towards each other. So the pH is going to be down and the C8 bicarb is going to be down. In alkalosis, the pH is going to be up and the bicarb is going to be up. So how do we treat these things? Well, we usually don't directly treat the acid base. Like we don't usually give anything medicine-wise to specifically address it. But what we do is we try and focus on the disease process that disrupted the balance to begin with. Respiratory support is important. Fluids and electrolytes are important. We're going to manage safety and comfort. Remember, people in these situations are often very anxious, and they can be can have altered CNS, altered understanding of what's going on. So we need to keep them safe and as comfortable as possible. We're going to monitor for complications of whatever we do and support their compensatory mechanisms. Remember that one? We're going to talk about a specific example in diabetes, for instance. And of course, the family and the patient always need some education. So for metabolic acidosis, we're going to focus on treating the underlying cause. So for instance, diabetics might be in a metabolic acidotic state. We're going to manage carefully their blood sugars and try and bring them down to normal. Whenever we try and correct it too quickly, though, we get into trouble. So we need to kind of go gradually, not too quickly, but of course we need to move things along. They can develop hypernatremia and hyperosmolality. They can develop water retention, so we just observe for these things. These would be complications of therapy. If someone has metabolic alkalosis, again, we diagnose the underlying cause. These are complicated medical situations usually. We're going to assess ABGs. We're checking serum electrolytes, urine pH, EKG patterns. We'll restore normal fluid balance and give potassium and sodium solution. They might use an acidifying IV solution, but usually not. Usually they'll be able to, we'll be able to get them back into balance without something that drastic. That might move them too quickly and get us into more problems. But these folks are at risk for gas exchange due to respiratory compensation. Remember, the body's always going to try and compensate. So if you have metabolic alkalosis, what do you think the lungs can do to hang on to a little CO2 and try and make the body a little more acidic? Well, they slow down the breathing. That's why these people are, bottom point, at risk for impaired gas exchange, because they're trying to hang on to the CO2 in order to make themselves more acidotic, and that means they may hypoventilate as compensation. Respiratory issues are often easier to fix. So respiratory acidosis, if they're not breathing enough, if they have respiratory acidosis, we're gonna fix that problem. We're going to improve ventilation. Make sure the air starts going in and out more, if at all possible. We'll talk about chronic respiratory acidosis when we talk about COPD. Of course, narcotic overdose is probably one of the more common things that you might see in the acute situation, acute care. Respiratory alkalosis, you could focus on correcting the imbalance and treating the underlying cause. So if the person is hyperventilating because they're anxious, we're going to try and manage their anxiety, help them manage their anxiety, help them calm down. If it's an iatrogenic problem, if we've got them on a ventilator and we're breathing them too fast, a ventilator will give a certain number of breaths per minute and a certain volume, so the machine figures out how deep and how fast someone should breathe. Well, if they've got respiratory alkalosis and they're on a ventilator, we're going to turn down the ventilator. We might slow down the rate, we might decrease the volume a little bit, but we'll do something to sort of calm their respirations mechanically. And of course, if it's a head injury, that's a very complicated situation. I think you talk about that in Med-Surg 3. At any rate, someone might also be hypoxic along with this respiratory alkalosis, as in the early stages of asthma. And at that point, we would want to give oxygen, supplementary oxygen, so that they don't have to breathe as quickly and that they can retain some of that CO2 that they need. And that's the end of this little very introductory lecture. We'll play with it some more in class, and I'll go on to talk about pulmonary problems like COPD and asthma and pneumonia in my next installment here. Thanks.